Okay, I think we're live. Well, welcome everyone back to another virtual shouting session at Hearts for Health. This is the first one of 2024. Very, very excited for this one. I hope y'all have had a good start to your 2024. I know mine has been really nice. 2023 was definitely a challenging year. 2024 is off to a great start. Hope that's the same case for y'all. But today, we'll have a couple reminders for you as usual. I do want to talk about one of our programs that was just recently released before we get on to Joan's, our speaker's presentation today. But before I do get onto this program, I do want to go through those usual reminders. If you've been on our program, have watched our sessions before, probably old news to you, but if you're new, I do want to mention that, or these, just in case. So today we'll be talking about pediatrics. Joan is a board-certified pediatrician, and she's also a second-year neonatal and perinatal medicine fellow. So very excited to not only see pediatrics as a specialty, but also neonatal and perinatal medicine as a subspecialty. I don't think we have yet seen that, so it'll be a first time for virtual shadowing. A couple reminders, though, if you're new, we do have a Q&A at the end of each of these sessions. So these sessions usually last for an hour. Towards the last 15, 20 minutes, anytime we have remaining after the presentation, we'll go through that Q&A. Any questions that y'all have, you can type them in at any point in time, and we'll get around to them during the Q&A. Like I said, 15 to 20 minutes dedicated to that. So we usually are able to get around to all the questions we have. Another thing I want to say is, if y'all are interested in staying up to date with more shadowing sessions, we do have two ways we post and announce flyers about these shadowing sessions. First being Instagram. Our handle is at hearts_for_health. And our listserv as well. Our listserv is something that you can either DM us over Instagram or email us or just sign up through our website to join. At the very bottom of every webpage on our website, which is hearts4health.org, we have a subscription form to the left. Fill that out, click submit, and you'll be good to go. That listserv is sent on a weekly basis on Thursday mornings. And it includes almost everything that you'll see on the Instagram page, but sometimes a little more detail to them. That's all I want to share about general reminders. With this new program, though, this is something that we just started out in 2024. So a very exciting addition to the clinical and non-clinical volunteering programs we already have going on. I don't want to take up too much time because we're here for virtual shadowing mainly, but I do want to share this with y'all because it is something that we're just introducing. So this program is called MedTank. It's basically a spin-off of Shark Tank. And the idea is we have contestants and project developers. Contestants are the people proposing an idea. While we do have the program titled MedTank, you don't necessarily need to have a medically related idea. The gist is that we have more so service-oriented ideas. And the whole point being that since us as an organization, we've created quite a few service-oriented organizations. We have 4 in total outside of virtual shadowing. We're really able to help leverage that experience towards ideas that people in our student audience have, right? And anyone who wants to propose an idea, we can term a contestant. At the same time, we do need manpower to support those ideas, and that's where project developers come in. So we will have, or we do have right now, applications for contestants and project developers separately. Contestants who we review and select, they will first go through sort of an interview, a pitch, just like you see on the show Shark Tank. It's not recorded or anything, but it's essentially like an elevator speech where you'll introduce your idea, discuss it with our panel, and from there, we'll discuss if we'll move forward with the idea, and if so, how many project developers we will delegate towards being on your team. Essentially, the whole point is, while we're not able to fund ideas, because as a nonprofit, we don't ask of any funds from our students, so what we're doing here is more so investing in the manpower required to make an idea happen, right? That's how Hearts for Health came to be, and that's how we hope a lot of ideas through MedTank come to be as well. A couple more things that are more specific to the roles. So as contestants, again, your pitches are not limited to the medical or healthcare field. Anything service-oriented is fair game. In fact, we do have more specific guidelines on ideas that can be submitted in our application, which I will be sharing with y'all at the end of this presentation here. Only a couple more slides. This slide is about project developers more specifically. Only a couple things I want to highlight here. As a project developer, there are a couple commitments time-wise that y'all have. The first being that when we have a project developer, they get added onto what we call a roster. That roster is essentially a way that project developers can have choice over what ideas they join. So a contestant will, if they are selected, join our Slack, which is where we work over, and then we'll have project developers also on that Slack. As ideas from contestants are accepted and onboarded onto MedTank, those will be sent to project developers who are on our roster, and they can, on their own terms, choose whether or not they want to join the opportunity. They have 4 months to be on our roster. That's the expected commitment. If someone was not interested in continuing after that, that's up to them at that point. But once they are, let's say, on the roster and they've selected an idea that they're interested in, now they can join the team. On the team, they're expected to commit at least 4 hours per week for a minimum of 4 months once they do join that team. And then the last slide I have here includes QR codes to both the contestant application on the left-hand side and the project developer application on the right-hand side. If y'all have any questions, feel free to email us. Towards the end of each of these sessions, I have the video description included below these live streams. So you'll see our email contact. You can also go to our Instagram. Feel free to DM us. We're happy to respond to questions either way. But like I said, I don't want to take up too much time. So moving on with our presentation, Joan, feel free to take it away.
Just give me a second to share my screen.
No problem.
Does that look okay to you guys?
Perfect.
All right, perfect. All right, it will probably be a little bit relevant a little bit later on in my talk, just kind of talking about my background in BME with your MedTank idea, actually. So that's a nice little segue. But hi, everyone. It's nice to be here and talking to you guys virtually. I'm Joan Lien. I'm a current PGY5, so I'm a second-year fellow in neonatology. So it's like a really long name, neonatal perinatal medicine fellow, but it's just the NICU. But I'm really excited to kind of talk to you guys about how I picked neonatology, how I got into medicine, and then maybe kind of share a little bit insight in that, not every journey is the same, and that there are people who go kind of a non-traditional route. So you don't immediately have to go from undergrad into med school and then, right into residency and things like that. So like I said, just kind of briefly what I plan to talk about today, my journey, how I got into medicine, why peds and NICU, just very briefly about fellowship life, because I feel like it's kind of vague and, you don't really think about it until after you get into medicine as well. And then I'll go into some case presentations at the end. I put this little snapshot of my journey into fellowship, and I've been working on my CV because I'll be job hunting like later this summer and fall. And I was like, how do I fit my whole life story into like as few pages as possible? I can apparently do it on one slide too. So here it is. So I went to Tulane University for undergrad and graduate school. My major was in biomedical engineering. That's what I got my bachelor's and my master's in. And I've actually, before I even went into undergrad, I wanted to go to med school. And I'll admit, partly it was because like this, underlying wanting to make my Asian parents proud thing, but I've always really liked helping people. So I did go into college thinking I'll probably major in like neuroscience and also complete my pre-med track. And then my first year, one of my senior RAs, he was a biomedical engineering senior, and he was telling us about his senior capstone design project. So at Tulane, when you go into BME, in your 4th year, you take a design class and you get assigned a client, and you have to design a product and actually build it to suit what their desire is. So his was, they redesigned a wheelchair for somebody to be able to also stand up in their wheelchair. And I just thought that was really cool. So after that, I switched my major over to BME, and I regret nothing. I will say it was super hard trying to balance engineering classes and also trying to complete like pre-med classes as well. But I think it was worth it, worth the experience at least. Um, I also think that biomedical engineering was like a very interesting and helpful degree to go into, because we had to actually take a lot of like anatomy and physiology classes, and even some of our like finite element modeling classes had to do with physiology and kind of how the body works. And I felt like that was at least a good intro to like very basic med school classes. Um, so my senior capstone design project was actually designing and building a violin bowing prosthesis for our client. She had a congenital transradial amputation. So she was born with like part of her limb missing, but she came to us and told us that she wanted to be able to learn how to play the violin with her sons. And so that's what we did. Our team built a violin bowing attachment that she could use. So we like designed a socket to fit her, and then made this attachment that would fit onto her violin bow. So that was kind of like a very gratifying end product to be able to see it come to fruition. And then like in BME, you also have the opportunity to participate in other design competitions. So one of them was the idea team design. And similar to y'all's med tank idea, you try to come up with solutions to different problems. So one of our proposals was what we call Tough Clave, which was a modular, portable, rugged autoclave. Thinking in sense of like Doctors Without Borders, places where they might not have like sterile equipment, might not have access to things like steady electricity, how they could be able to sterilize their medical equipment in the field. And then we also had to write like a thesis for both undergrad and graduate. And mine was looking into kind of the wear properties and biomechanical properties of pyrolytic carbon and ultra high molecular weight polyethylene, which are two materials used in knee implants. Because the lab I was working at the time was trying to develop a knee implant and get it FDA approved. So that was part of it. In undergrad and grad school as well, one of the, I think, big influences in me wanting to continue medicine. I was part of Tulane Emergency Medical Services called TIMS. And Tulane is pretty unique because they have like a student-run EMS organization. And at the time, we actually had 3 ambulances. We had a truck for like our crew chiefs and our supervisors, and we were all EMT basic certified, but we basically ran our own EMS service. It had like a pretty large service area as well, and we would transport like students and then faculty and staff, anyone who needed any emergency transport from like our service area to our local hospitals as well, which was pretty unique. By the time I graduated, I had dedicated, and most of us actually, like over 2,000 hours of volunteer service, which I think also helped with like my application going into med school. And then that it being student run also gave us the opportunity to kind of run our own committee. So to being on the continuous quality improvement committee, and whatever profession you go into, you'll kind of learn that quality improvement is like very desired in any field, because like every like business is going, or hospitals or everyone wants to continue to improve and see where things can be fixed or how it can be optimized. And then also field training officer, where you kind of learn how to teach your peers as well. And that's also like a really good life skill. I was part of a sorority. And then when I had started undergrad, it was shortly after Hurricane Katrina had happened. So there were also a bunch of outreach opportunities and chances for where a bunch of us wanted to try and help rebuild New Orleans. So lots of different volunteer activities as well. So after I finished undergrad and grad school, I was kind of, I'll admit, a little bit burnt out. So I wasn't quite ready to take the MCAT yet, and really honestly needed a break from school. So I decided to work for a few years while studying for the MCAT. The research lab I had done my thesis at had offered me a position, so I ended up staying on at the Fellowship of Orthopedic Researchers. And during those years, I got to help design test fixtures, play with 3D printers and scanners. We do a lot of wear testing of implants there. And you can kind of see in that middle picture, that's actually how they test some spinal implants, and they do dynamic testing in it. So the blocks are supposed to be like your lumbar spine, and then that's the implant device. And then we look at like histologic samples. So after we drill it into like sample bone, or after animal studies or whatever, sometimes these implants have coatings on it. So we want to see how the coating is affected, if bone grows into it, if it shears off. So we did a lot of electron microscopy for that stuff and particle analysis as well. And then we also did a bunch of like finite element modeling too. So that was a good experience in kind of seeing how like another side of things, the development of implants and the different things that we use in the hospital every day, how those things are designed and come to life. So after I took some time off, regrouped, I finally made that big step and took the MCAT and applied for med school. I went to LSU in New Orleans because in-state tuition is great when you already have a lot of debt. And just kind of briefly how at least med school was there, and just a brief overview. Your first 2 years are a lot of coursework. Ours was very systems based. So going through all of your different systems like neuro, respiratory, GI, GU, and then learning how to form differential diagnosis that can fall into those categories. So they kept on referring to it as like a filing cabinet. So like if they had like upper abdominal pain, you have a filing cabinet of differential diagnosis for causes of upper abdominal pain. So things like reflux or trauma, pancreatitis. And so it kind of helped you learn how to start thinking broadly and how to kind of figure out what's going on. During those years is also when you're starting to prepare, and then you eventually take step one, which is kind of your big first board exam. And then third year is the fun year, and I would say also fourth year is because that's when you actually get to start seeing patients and being in the clinical setting. So your third year is when you start your clinical rotations. And so the big ones are the pediatrics, internal medicine, surgery, OBGYN, family medicine, psychiatry, and neurology. And it's kind of figuring out what you like versus what you don't like, and then prepping yourself for what you will want to apply for residency. I went into it thinking that I would be more interested in things like emergency medicine because of my EMT history, and then also possibly ortho because I had a lot of experience working with orthopedic surgeons when we were like developing all of our knee and spine implants. But then my first rotation was actually in pediatrics. So I went into it thinking, oh, there's no way I'm going to want to work with kids. Like they're all snotty, they're gross. That doesn't seem as exciting and interesting, but then I actually fell in love with it. So I will say, if you go to med school and you're starting your clinical rotations, just go into it with an open mind, because you never know what might surprise you. There might be aspects of it that you didn't know about until you are actually in that setting. And then at the end of all of the rotations, you take your shelf exams. Then fourth year is kind of when you should have an idea of what you want to go into, because you start doing your acting internships, so your AIs. So like I did a pediatric internal pediatric inpatient AI. I also did like a NICU AI. And that's where you are acting as the intern, which is like your first year residency. And then you are supervised by other residents as well. But we were able to do like primary AIs in like family medicine, internal medicine, OBGYN, peds, or surgery. And then secondary AIs are those that are like subspecialties. You can also do electives and then away rotations. So fourth year is pretty flexible for us because at that time you're also applying for residency and doing interviews as well. So that also takes up like a very large chunk of your time. But it's kind of about exploring what your interests are. I think away rotations are something I hadn't thought about until going into fourth year med school, but you basically apply to kind of fill a position at another hospital somewhere else. So I actually did an away rotation in the PICU at UNC in Chapel Hill. And I thought that was a really useful experience because you might be applying for these places for residency, and you actually get to go there and see what it's like on the inside, and while you're working with some of the current residents as well, and you can kind of see how they interact with each other, if they have the right camaraderie that you're looking for as well, the right teaching environment. So I highly recommend, like, if you are interested in like a specific location for residency, that you try to apply there for an away rotation, because even if you don't think that you'll have a shot at getting an interview for that location for residency, sometimes doing a rotation there, you can be like, hey, I happen to be here for an away rotation. Can I get an interview as well? And they might also allow that. So just things to think about. And then your fourth year, obviously, that's when you match after you finish your applications and interviews for residency. And match day is always in March, and it's super exciting because you finally figure out where you're going to end up training. Plus, you graduate and have your medical degree. And then just kind of talking about extracurriculars, things to think about participating in. So in med school, they have interest groups, and that's a good opportunity for you to get to know what specialty you might be interested in a little bit better. So like I was part of pediatric interest group, emergency medicine interest group, and orthopedic interest group, because those were the ones I was most leaning towards. They also encourage you to do research, but it's not required. I had already done it prior to going to med school, so I didn't do any of that. And then I would encourage you to do as much community service as possible while you're in med school, partly because you get some clinical experience. So a lot of times it's going to be taking histories or taking vital signs, or giving vaccines like flu shots or doing PPD shots. And all of those are just, it's really good to kind of slowly start to get immersed in the medical environment and get a little bit of practice while you still have a lot of support and people around you to check and make sure you're doing the right things. And then the last thing that was kind of an exciting venture in med school was I had some friends in med school who were also biomedical engineers at background, or were interested in kind of more design aspect and trying to innovate a little bit. And then with them, we started the first New Orleans chapter of Sling Health. So Sling Health is a medical engineering design incubator, and kind of similar to what you guys were talking about, just bringing in ideas and then trying to come up with solutions to those ideas as well. One of our big in projects for when we had started that was we put together a workshop. So I had invited one of my professors from Tulane to come and talk to us about brainstorming. And so prior to that workshop day, we had kind of collected a certain like real life problems that different medical professions face, and we brought those questions in, and that's what we brainstormed solutions to. And we had invited people from medical school and then from like undergraduate programs to our workshop event, and I thought it was really successful and like a really good experience as well. Okay, so why pediatrics? like I said, after doing my clinicals, I realized I didn't want to do surgery or emergency medicine. And I actually had the best time on my pediatrics rotations. And after having worked for a few years, like prior to the start of medical school, I told myself that's what I really wanted. I wanted to find a profession that could spark joy in my life. And I found that I actually really enjoy talking to kids and talking to babies, even though they don't talk back, but they're the cutest. And kids are just so honest and say the funniest things sometimes. You also get to see a really interesting range of pathology. You see a lot of what you might see in adults, but you so like things like mild to severe asthma, you see different sepsis pictures, but you also see a lot of other things like Kawasaki disease or cerebral palsy. You see different things like leukemia, lymphomas, and a lot of times you are at the front end of it diagnosing it as well, since they're so young. So it's more like an acute presentation versus a lot of times like the adults have chronic diseases, like hypertension and things like that. And then another thing was that kids are surprisingly resilient. So that was also really amazing that they can just bounce back from being in the ICU one day and then like a week later, they're eating ice cream in their bed. You also get a lot of inpatient and outpatient exposure. So you have a lot of options as far as what kind of environment you want to work in. There's a bunch of different subspecialties as well. So all of the ones that adults have, pediatrics have as well, plus some other options. And then you meet the nicest people, honestly. I don't know if anyone watches like Dr. Glaucomflecken and his videos, but I would say that his videos are a very accurate representation of PEDS people. My friends send me the videos all the time of like him being a PEDS person or a NICU person. And everyone that I worked with on my pediatrics rotation, they were just like very supportive, and they wanted to teach us and wanted to involve us in like clinical decision making. And it was just a really good environment to work in. And then I'll also say like going into NICU, my NICU rotation was actually my very first clinical rotation I did. And at my med school, we actually did a longer NICU rotation than I would say most others do. We did 2 weeks just to start off with. So we actually got to pick up patients and follow them. And I think that has also impacted my decision because I really got to get some hands-on experience. And then I'll also say that you will find that the people you work with really impacts your experience as a whole. So I hope that whatever you decide to do in the future, you do carry that forward, thinking about like how you want to be treated and kind of doing the same for others when you do get to be in a position where you can make a positive impact. Okay, so neonatology, my subspecialty now. So what does a neonatologist do? We provide very comprehensive care for critically ill, both preterm and full-term infants. So from it may be from birth or like a few days after from birth up until discharge. And then we actually even take care of them partly after discharge because we have follow-up clinics. So. But we often start by doing like antenatal counseling if like a preterm delivery is expected, or if there are congenital anomalies that are found on prenatal ultrasound. We attend high-risk deliveries, which might include preterm babies or just expected low birth weight. They might be big for size, or like I said, if they have prenatally diagnosed abnormalities. We attend those high-risk deliveries and do like resuscitation because they might be expected to need a little bit extra support. We also get to do a lot of procedures. So that was important for me. Part of the reason why I was interested in like emergency medicine, ortho to start, was because I do like doing procedures and I like a lot of hands-on activity. And I found that in NICU, we get to do a lot of that. So we do things like intubation, we do chest tubes, we can do thoracentesis or paracentesis, or even pericardiocentesis. So all of those is just like drawing fluid or air out of the lung space, the stomach, like the abdominal cavity space, or like if around the heart. We can do umbilical lines, we can do PICC lines and arterial lines, and we also do lumbar punctures. So a bunch of procedures and hands-on activities. And then we also get to see like a huge range of pathologies, anywhere from respiratory diseases like respiratory distress syndrome, meconium aspiration, encephalopathies, intestinal or anal atresias, and a bunch of cardiac abnormalities. And then we also get to help identify and diagnose congenital and genetic disorders like trisomy 13, 18, or 21. And then there's a bunch more with different abbreviations. There's a whole list of them. And then our patient population is actually a very wide range. So we take care of babies as early as like 22 weeks gestational age. And then some moms may have maybe post-term, so up to like 42 weeks of gestation. And then we care for them as long as they need. So I feel like you also get a little bit of continuity with that. Some of our patients in NICU stay until they are several months old. And I'm talking like almost celebrating their 1-year birthday in the NICU. And then we also get to do some other interesting, more complex therapies too. So one of them is neonatal ECMO, which stands for extracorporeal membrane oxygenation. And it's basically like life support for babies who may have severe respiratory or cardiac failure that has been unresponsive to all other therapies. And then another interesting thing that we do is so it's called therapeutic hypothermia. So we do whole body cooling for infants who may have had a little bit more of a rough birth event. So they may not have gotten enough blood or oxygenation while they were being delivered, and they might have a little bit of brain damage. And the whole idea behind this is to kind of slow biological processes down and kind of limit any brain damage from furthering. Just a little bit about NICU fellowship. So it is a 3-year fellowship. So you, after you finish your pediatric residency, which is 3 years, then you apply for fellowship, and then that's another 3 years. Hence why I'm a PGY5. There's a bunch of programs all over the US. You apply your fall of your 3rd year through a similar process that you apply for a residency for. If you guys are interested in med school and will be applying for like residencies or for fellowships later on, I recommend using programs that can help you kind of sort through a lot of them, because there are a lot of programs in the US, but one of the ones I used a lot was called FRIDA, and it's through the AMA, but you can help look for like ACGME accredited programs, which is really where you want to go. There are different levels of care. So they have levels 1 through 4, and unlike like trauma centers where 1 is like the most acute, NICU is just a little bit backwards, and level 4 is actually the highest level of care for babies. And like where I'm training right now is at OU Children's in Oklahoma City, Oklahoma, and we are the only level 4 in the state. So as far as like acuity and sick babies, we are it. During fellowship, you get to work with very multidisciplinary teams, which I think is great. You may be rounding with neonatal nurse practitioners or residents. They're bedside nurses. We have NICU dietitians and pharmacists that round with us as well, and then the respiratory therapists. We also work really closely with our pediatric surgery colleagues, as well as cardiology, our GI colleagues, urology as well. Basically all of the subspecialties we will come in contact with. And then as far as like our time or how our 3 years are spent, different programs will split your time in fellowship differently. per ACGME, you have to do like a minimum of 12 months dedicated to clinical experience and then 12 months dedicated to research and scholarly activity. So like my fellowship, we do 13 months of clinical service, which includes like cardiac ICU time as well, and then maternal fetal medicine. And then kind of divvying up the rest for research activity, and then taking into consideration that we do a lot of like call time in between that too. And then also per ACGME, we have to have like a follow-up clinic. So we do clinic for high-risk neonates. So after discharge, say they're on like oxygen or have a G-tube or something like that, we might see them a little bit more closely after they get discharged, just to make sure they're doing okay and help wean them off of the oxygen at home. And then we also do developmental follow-up like a year and 2 years, and we do screening for them there, just to make sure that they are on track with meeting their developmental milestones. And if not, then we help get them plugged into the resources, like getting them into therapies, which can help them catch up. So unfortunately, all NICU fellows have to do call. Call is basically where we take care of the unit overnight, along with our night team. On average, we do like 3 to 4 calls per month. So if we're on service at that time, that might mean doing like a 24 to 28-hour shift. And then the attendings, depending on where you go, maybe in-house or take home call. At OU, our attendees are actually in-house, which I really like. And I like that they are there just in case there's a code happening, they can be there immediately. And then I will also just mention, I think when you're interviewing, I think it's important to kind of get a gauge of how much autonomy the fellows will have. So I like that at my program, we get kind of like a graduated autonomy level. So as you advance and learn and gain trust, the more autonomy you have as well. And then we do have learning time too. So other curriculum things that we do, we have weekly fetal and neonatal physiology seminars. We do weekly conferences too, where we present certain cases or certain topics to our co-fellows and to other attendings in our department. We have grand rounds, monthly journal clubs, and then we have a bunch of training courses like an ECMO training course and then procedure boot camps. And then we also do simulations as well. Okay, a day in a life of a fellow. So it kind of depends on what rotation I'm on, whether it's clinical research. This is obviously going to be like if I'm on clinical inpatient team. So I'll pre-round, so get to the hospital before we getting signed out to kind of chart check everyone. We get signed out from the night team around like 7:45. And then during that call, we also identify potential discharges or transfers. And then after that, I finish pre-rounding, and then we'll actually round on the patient. So we usually start with x-ray rounds around 9, and then we do walk rounds with the team where we walk to like bed to bed, and then we'll talk about the patient's overnight events, any vital sign changes, kind of the plan for the day, any orders. And then we do like family-centered rounds. So we like the families to be involved in decision-making. So we like them to be there as well. Then we do orders and making sure all of our labs and everything are in. Sometimes if you're with the resident team, we do a lot of bedside teaching for them. And then if we don't get a chance to hit certain topics, then we'll do teaching in the afternoon afterwards. After we round, we check on all the patients again and kind of follow up any changes that were made. And our sign out is like around 4 p.m. If you're on call as well that night, then you get sign out from all of the teams in the day. I'll go check in on what we call the watchers or like the sicker patients. We do safety rounds with our labor and delivery colleagues to identify any potential deliveries that might happen in the middle of the night or anything that they are concerned about, or if they need any consults. We do night rounds on the sickest babies. And then at night, we also attend high-risk deliveries, take transport calls because our hospital is also a level 4. So a lot of community hospitals end up sending babies to us, and then managing any sick patients or acute events or anything that needs following up overnight. Okay, that was a lot of talking. So I'm just going to do some case presentations now. All right, so case one. We have a 2.9 kilo male who was born via repeat C-section at 39 weeks gestational age. Rupture membranes were at delivery and clear. APGAR scores, so they score them after they're born, and they're 8 and 8, which are good scores. But he has coarse breath sounds and begins grunting. His temperature is fine, his heart rate is fine, but he's breathing a little bit fast. They start continuous positive airway pressure or CPAP, which does improve his work of breathing. What would be on your differential diagnosis? And this is like, I know it's very specialty specific as well. So I'm just going to continue on and kind of go over some things. So this is what I was talking about, like a filing cabinet of differential diagnosis. So for this one, we're just talking about respiratory distress of the newborn. That's kind of the baseline problem. So these are just a few things that I would kind of tick through in my brain. So they might have what's called transient tachypnea of newborn, respiratory distress syndrome. They might have aspiration syndrome of meconium blood or amniotic fluid, pneumonia, a pneumothorax. They might have a cardiac defect. They may have persistent pulmonary hypertension. They might have congenital diaphragmatic hernia. They might have a congenital pulmonary airway malformation or bronchopulmonary sequestration. So what do we do to figure it out? So we admit him to the NICU, where we continue his airway support, and we get a chest X-ray on admission, which is shown here. What would be the most likely diagnosis?
I'm keeping tabs on the chat here, but
Oh, really? Oh, perfect.
yeah, we're still waiting on responses. But while we wait, one question that did come up is you talked about being an engineering major, right? And I guess even during medical school, you incorporated it with Slink Health. I've actually heard of Slink Health, really admire the work over there. Really cool work that y'all do over there. But a question that had come up is, I mean, you were able to extend it into medical school. Beyond that, have you or do you see yourself sort of developing a niche for yourself when it comes to innovation, like outside of one-on-one clinical practice? Is that something that you're interested in or something that you've seen colleagues do?
I feel like it's something I think about all the time. Like it's always in the back of my brain. Whenever like we're putting in lines, so like putting in umbilical lines or something, I'm always thinking to myself, like, I know that there has to be a better way to do this to be more consistent with being able to get it in, because sometimes it just goes in the wrong spot. So I feel like it's always in the back of my brain, and I would love to do something more innovative later on. I will say that fellowship is like pretty time consuming, and so is residency in itself. And like you have to do like research projects and QI projects in both residency and for fellowship. And I do think that it takes up a good chunk of your time. I think that if you are at a program that can support maybe like if you have an idea in mind already, that like a project that you want to do, and you're at an institution that has like good support for it, and being able to use it as your research project or something like that, I think that would be most ideal. I haven't been able to do that so far, but it is something that I want to continue pursuing as I go forward. I think that would be really fun.
I definitely think so too. I really admire the physician engineers that there are. Very few and far between, but incredible things that they can do. From the chat, I do see one response. We have TTN.
Yes, that is exactly what this is. So this is TTN, transient tachypnea of the newborn, which is a benign self-limited condition. And just for whoever wants to go to med school or whatever you want to do, a lot of times the name will kind of spell out what it is. So transient, it's a very self-limited, it comes and then it will go. Tachypnea, so they are breathing fast, and then of the newborn, so a newborn baby. So it's a benign self-limited condition. It does present in infants due to delay of clearance of fetal lung fluid after birth. It can lead to respiratory distress and tachypnea. It usually resolves within 48 to 72 hours of onset. I'd say if this is what you're expecting and then they aren't getting better, then maybe think about other things on your differential. And then chest x-ray findings can show what we call prominent perihilar vascular markings. So you can kind of see like a little bit of congestion right around the center area. And then the arrows are pointing to fluid in the fissure. So your lung has different lobes, and you can actually see if there's a lot of fluid, at least like fluid lines where the lung lobes are separated. All right, case number 2. So we have a 1 kilo male infant born vaginally at 28 weeks gestational age after mom came in preterm labor. APGAR scores are 6 and 8. He has decreased air entry in his lungs. He's a little bit cyanotic. He's retracting, grunting. His temp is fine. His heart rate is a little bit high. He's breathing a little bit faster. They start CPAP for him as well, which does improve his work of breathing, but he's needing a lot of oxygen to keep his sats where you want them. What is on your differential diagnosis? So very similar things, pretty much exactly the same list of things. He gets admitted to the NICU where CPAP is continued, and his chest x-ray on admission is on the left. What is the most likely diagnosis? And I'll just give it a second for the interest of time because I know we're kind of cutting it close. All right, so this is just a little bit different. So this is respiratory distress syndrome, so RDS. Compared to the previous one, which was TTN, it more commonly presents in preterm infants, although you can also see it in term infants for like moms, for babies of moms who have like diabetes or other kind of disorders like that. But more commonly in preterm infants, it is caused by surfactant deficiency. So everyone has what's called surfactant in their lungs. It's naturally produced. And the goal of surfactant is to decrease surface tension in your alveoli, so it keeps them open. When you don't have it, it increases their surface tension in the alveoli and makes it have a higher tendency to collapse. And so you get atelectasis, which is basically a bunch of collapsed airways. And you have very low lung volumes. So you don't have enough space for like oxygen exchange to happen. So it can range from mild cases where they might just need a little bit of breathing support, but severe cases like what you see on this x-ray here, where you see this ground glass infiltrates. So it's just super hazy all throughout, all the way to the edge. They might require like a breathing tube. They may need to be intubated and for us to give some surfactant. All right. Case number 3. So you're called to a birthing room to evaluate a term infant who started showing signs of respiratory distress immediately after delivery. She was born to a mom with poor prenatal care. On exam, you notice that breath sounds are difficult to auscultate on the left and heart sounds are muffled, and you think you hear bowel sounds instead. What's on your differential diagnosis? Also just flipping through this one because similar things, just kind of learning your filing cabinet of differential diagnosis and thinking it through. And then for each one, I tend to be like, oh, this one is more unlikely than the other one, and kind of rank them. So he gets admitted to the NICU where you get an x-ray and it looks like this. What is the most likely diagnosis?
Nothing so far in the chat.
Okay. So this is congenital diaphragmatic hernia, a CDH. And it can commonly present in the neonatal period with respiratory distress. Most of them are left-sided because your liver is on that right side, so it prevents the rest of the bowel from coming up. But it's basically where you have a hernia in your diaphragm, and so you get like your abdominal contents go up into your thoracic cavity space. Depending on how bad the defect is, it can also result in your lungs not developing very well. And with that, you also get pulmonary hypertension because your lung vasculature is also like abnormally developed. And then you can also see anomalies in like 50% of cases. So on x-ray, you might see this like herniation of abdominal contents. So you can see that this is the giant stomach bubble here. And then you can see that all of the other structures get displaced. So like the heart's getting squished over to the right, the lungs, the contralateral lungs also getting squished as well. And sometimes they just like end up having like a tiny bleb of like a left side of their lung as well. When these get prenatally diagnosed, we come to the delivery ready to intubate because we don't want them to breathe in and maybe like expand their stomach bubble, because that will make it harder for their lung to kind of work in that very small space. So we intubate if they have any respiratory distress, and we want to avoid anything that might just in their abdomen. We also put like this tube in, which can help pull off air in their stomach. And then we call our surgery friends because they are the ones who are going to fix this. They fix the hernia, they put everything back in its place. And sometimes in really bad cases, these are babies that end up on ECMO. Do you think we have time for one more, or you think?
I think we will. Yep.
Great. All right. So this is a 2-week-old X25 weeker female infant coming in with feeding intolerance and abdominal distension. The NICU team has been advancing her feeds and recently fortified them. You notice that her heart rate has been trending up and that she's been having a lot of desaturation events in the last 24 hours. What's on your differential diagnosis? So this is a little bit different than the other ones. So this is a filing cabinet for abdominal distension of the newborn. So especially for preemies, you think about necrotizing enterocolitis or NEC. You always want to think about malrotation. They may or may not have what's called volvulus, meconium plug or ileus. You think about sepsis always. They'll always be on their differential for anything, spontaneous intestinal perforation, or they might have a GI congenital anomaly like pyloric stenosis, atresia, or intestinal atresia. You get an x-ray, which looks like this. I'm just going to flip through it. So this is necrotizing enterocolitis, and then kind of like the buzzwords that we say, you are talking about like a preterm baby with like this abdominal distension, and you always want to think about NEC, especially if they've been advancing feeds and fortifying them, and then they get this. And she's like right around that time point too, right, that 2-week mark. So it's a really bad life-threatening disease. It primarily affects preterm infants, but has a super high mortality rate as high as 50%. Not a lot is known about NEC and exactly who gets it and why it's caused. But essentially there is like intestinal inflammation that can lead to necrosis. And then the intestines can perforate. You can get really bad peritonitis, you can get sepsis, and then death. On x-ray, the buzzword for this is pneumatosis intestinalis. You can see this red arrow is kind of pointing to this railroad tracking of the intestinal wall. Basically, you have like the bacteria that causes hydrogen gas, and then it can kind of like seep into the wall, and that's one of the telltale signs and diagnostic signs on x-ray. And then the other one is what's called portal venous air, which is when that gas travels up to the portal system in the liver. And you can see that with where the blue arrow is pointing, and that is also a bad sign. I'll do the last one just because it's more interesting. So this is the last one I had. You're called to delivery of a 37-week female infant because there was prenatal concerns for abdominal wall defect. Baby is delivered, and then bowel contents appear to be externalized with a sac covering the outside. What's on your differential diagnosis? So this is just kind of differentials for an abdominal wall defect of the newborn. So you can have what's called omphalocele versus a gastroschisis versus a large umbilical hernia. There's something called ectopia cordis, which is part of like this huge syndrome thing. You can have limb body wall complex, something called cloacal extravy. And then the infant's abdomen is seen on the left. So this is what's called an omphalocele. It is a midline abdominal wall defect. It has a membranous sac, and basically you have this giant hole where it didn't close up very well, and so all of your abdominal contents is kind of outside. The size can vary as well. You can have intestine, liver, spleen, bladder, gonads. Basically anything can be in that area depending on how big it is. And it is commonly associated with like a congenital or chromosomal anomaly. And then the size of the defect can also affect development of other organs like lungs. So you might have really underdeveloped lungs because your thoracic contents were outside. That's really all I have. These are just some life pearls. I would just encourage someone just to, like everyone, to find a profession that really sparks you joy. It really makes it hard to like get up and go to work when you aren't looking forward to it. For myself, I found a place where I can do like hands-on procedures. I can talk to babies. I can take care of them, help them grow, and that makes me happy. So that's why I am doing what I'm doing. And we spend so much time at work. So I think it's really important for us to find what we like to do and want to do, and also to find people who we want to work with. So just be super mindful of like who you surround yourself with and make sure you're in an environment where you can grow and succeed. And that's really all I have.
Well, first of all, thank you so much, Joan, for this presentation. We always love to see cases. I'm very impressed by the student who mentioned TTN. Hit the nail
I
on the
know.
head. Might as well go into fellowship now. But yeah, we always love to see cases. Thank you so much for sharing them. Really interesting to see, especially given that this is the first time we've all seen the subspecialty on virtual shadowing. Just with the maybe 5 minutes or so that we might have, if that's all right, does that still work for you for a Q&A?
Yeah, I'm good.
Okay. All right. Well, we'll go through a couple questions, but if anyone has any other questions, feel free to type them in the chat. The first one, sort of again being related to the engineering question we had earlier. If someone is to try to fully lean into engineering as what they do, right? Is that feasible? Like instead of one-on-one clinical practice being their go-to, right, in terms of their day-to-day?
Like if they went to med school as well and like did residency like that, and then they wanted to work more on the industry side of things,
Exactly.
I would say it is feasible. I think nowadays you can pretty much find a niche for whatever you want to do. I think that if you go to med school, finish residency, like have done like a special, like some sort of subspecialty thing, like peds or internal medicine or whatever, I think that depending on what it is you were doing, you can always work as like a consultant for certain companies. I think that is very feasible. I hear they are very well paid as well. So I think that's always a possibility. Yes. You just have to go looking for it.
And to tag along with that, did that sort of subject matter about your engineering background come up during residency or fellowship interviews?
Yeah, every time. I think that they like it because I feel like in engineering, you have to do a lot of problem solving and critical thinking, which is like a very desired skill. So I think that, and it's a skill that's hard to learn too. Like when you're taking care of patients, trying to think through things and kind of talk it out, I think that is a very desired skill. And I think engineering definitely helped with that because you do have to learn how to solve problems.
That is true. I was shadowing a former engineer turned physician earlier. Definitely had a different approach to, I guess, thinking about his differential and all. So interesting to see how it plays in. And one more question we have, just to wrap up the session, is just generally, not necessarily specific to pediatrics or neonatal perinatal medicine, but just generally, have you noticed that the type or the program, like the location of the program that you find yourself in for residency or fellowship, plays a factor into um, how prepared you might be for academic versus private practice? Is that the case within a certain specialty? Like if I were to go to one side of the country versus the other, or a specific program versus the other within one specialty, would I be better prepared for certain sides of or settings of medicine?
Yes, because there are certain residencies that might be more like primary care focused versus like outpatient focused versus like a lot of inpatient time. So like my residency, we did a ton of inpatient time, which I am very grateful for because that's something I enjoy. And it like what you see, what you're exposed to is kind of like what you and like that's the training that you get, right? So some other programs might be a little bit more primary care focused, like they are dedicated to producing more primary care physicians, which I think is something that our country does need. And so you might choose a program based off of that. So I think if you kind of know going into residency, like what kind of practice you want to do, you can definitely tailor your search for your residency program based off of that. And then I think that even if you end up somewhere, you change your mind, like if you wanted to do private versus like more academic institution, your experience is kind of what you make of it. So like for our outpatient clinics and residency, we actually had the option to, in our third year, to go work in like a private outpatient clinic. So that might be something that you talk to like your residency program about and say like, hey, is this an option? Because that's something I'm interested in. So they may be able to like make opportunities happen, even if it hasn't been previously established. It just might be a little bit harder, but I think like a lot of times your experience is going to be what you make of it. And like if you're taking advantage of all of your opportunities or if you're kind of advocating for yourself as well.
One more question that popped in the chat was, during clinical rotations, are you able to incorporate subspecialties in the rotations, or are you limited to what the medical school allocates to you?
Um, it depends on your med school. So like during my surgery rotation, we had to pick a subspecialty rotation. So I specifically did pediatric ENT as my surgical subspecialty. So it will depend on what medical school you go to. So that's actually like if you're applying for med school, it's like a great question to ask them. Or like if you happen to interview with like other med students who are current students there, like talking to them, kind of questions to gauge what it's like what kind of freedom do they have.
Definitely something to keep in mind. We had quite a few people in the application cycle this year. So if y'all have any interviews coming up, I know it's winding down, or if you're going to apply soon, definitely a tip to take in mind. But that will wrap it up for today's session. I do have one more reminder for y'all, and that is the quiz that we have for this session is now posted in the chat box, the same chat box that y'all have been posting your questions in. We also have it in two more places, our website, on our virtual shadowing page. You'll see a quiz in a box to the left. If you scroll down just a bit, you'll see it marked as a Thursday quiz. And it's going to be due on March 6th, a Wednesday. We usually have these session quizzes due around 6 days after the session itself. It'll be due at 11:59 p.m. Central Standard Time, near midnight. And the third place you'll also find it is in the video description. In that video description, we've also included our contacts, our email contacts. If you ever want to get in touch with us for any questions about MedTank, this program, or any others. One more thing I do want to add is with that quiz, if you pass it, you have to get 6 or more questions correct to do so, and you'll receive a certificate. It should be sent automatically to the email address you list. If you don't find it, please do check your spam folder. Sometimes it does end up there, but if you don't find it either your inbox or your spam folder, feel free to reach out to us. We'll be able to sort it out for you. Our next virtual shadowing session will be actually this Monday, March 4th. We'll have it on pediatrics, but another subspecialty, pediatric hematology oncology with Dr. Smith. Same time, 7 p.m. Central as usual. And we'll be posting our flyer pretty soon about that. But with that said, let's have some thank yous in the chat for Joanne, who took the time to get this presentation together. So we really do appreciate your time, Joan. And I hope all of you have a great rest of your night. Enjoy your weekend. It's coming up soon.
Thanks for having me.